Okay, this is the third video, most likely the final video, regarding infection control. Any object, again, that becomes unsterile, this was the last slide from the previous video. Any object that comes in contact with the floor, with bodily fluids, with anything, becomes contaminated. So you're getting ready to give an injection and you drop the syringe on the floor. It could be completely full. I would consider it contaminated. Um, and if you cross a sterile field, it becomes contaminated, is no longer sterile. So anything you can do to keep um, a dressing, a syringe, anything you can do to keep it sterile or keep it clean as appropriate. Gauze pads. Don't put tape in your pocket and then put it on the patient, because you know how many times you stick your dirty hand in your pocket. Um, Tape should be patient specific. There's just all kinds of little things like that that you need to remember so that the patient stays as safe as possible. So, sites for a nosocomial infection to take place. All of these: surgical wounds, bloodstream, pneumonia, urinary tract, bone and joint, cardiovascular, nervous system, eyes, ears, nose, mouth and throat, GI system, reproductive system, skin and soft tissue. Here's what happens. You put in a Foley catheter and you contaminate the field and the patient gets a UTI, urinary tract infection. That is a nosocomial infection. Patient has surgery and somewhere along the line someone broke the sterile field. The patient gets a post-op infection. That is a nosocomial infection. You can get community-acquired pneumonia. You can get hospital-acquired pneumonia, and they're different. So, as you see on this site, pretty much any part of your body or the patient's body is susceptible to a nosocomial infection. It is your job to maintain sterile technique, clean technique, isolation precautions. What can you do? Well, let's talk about hand washing again, an aseptic technique. Also, remember that a patient in a facility is usually sick. They don't live there just because they want to. Even in a long-term facility, those people's immune systems are crashed down. Those people's immune systems are depleted, either from age, from illness, from a variety of things. So we also, along with maintaining aseptic technique, surgical asepsis, whatever the situation may be, we want to provide healthy alternatives for that patient so that their body is protected from being a host. Nutritional support. I can't say this enough. It doesn't matter what you do for a patient, but if their nutritional needs are not met, a child's not going to grow, an adult is not going to heal, and an old person is going to fail. That's just the way it is. Also, rest. People who are sick need to rest, and we have to be their advocate. A lot of families are awesome and they want to come and visit and, do all kinds of things, but sometimes that's not the best for the patient. And so we have to be the advocate for the patient and say, gosh, you know what? He just fell asleep. Do you mind coming back? And then we have to maintain the body's normal defenses. Putting in a Foley catheter might be necessary, but it is an invader. And it's not a natural invader. So we have to do whatever we can to make sure that that person's body is protected the best that it can be. Again, your body has a normal flora and normal bacteria, and those normal bacteria fight off other bacteria. So they do have a job. Your body also has other defense mechanism. Your skin has hair on it. It has hair on it because hair is the first line of defense to catch any kind of bacteria. In the respiratory system, starting with the nose, there's cilia. There's also hair, basically, is what it is. And that catches a lot of bacteria. Again, I told you in class, make sure you blow your nose at least twice a day. There is so much truth to that statement. You want to make sure that the patient is frequently coughing. It's called pulmonary hygiene, that they're inhaling really well, exhaling and coughing. Post-op, obviously that's good for their muscles, but it's even better for their lungs to get any kind of bacteria that could be in their lungs out. Your body also has inflammatory responses. So think back to your hangnail. You get a little hangnail, and a couple of days it's like kind of red, then it gets angry, and there's even some pus. Well, the pus is an inflammatory response. It's the body saying, hello, we don't want you here. And so we're going to form this army and surround the invader until we kill it. So whenever you see pus, yes, you got to clear it out and all that, but really ultimately it was a good thing. It was your body trying, and it is your body's way of stopping whatever the invader is from getting any further. And then you have an immune system, and that's where immunizations come in, this antigen antibody reaction. When you have an immunization, it causes a reaction of antibodies who, again, that becomes their job in the army of inflammatory responses. It's the job of the immune system to say, okay, this group is going to fight the flu, this group is going to fight measles, this group is going to fight mumps, and your body carries that army with it until it's invaded by that infection, and hopefully, and in most cases, those antibodies will do their job and fight the infection. It's actually a very cool process. Surgical asepsis is used obviously in the OR, but it's also when you're performing any surgical or any sterile technique. Again, a sterile dressing change, inserting a Foley catheter. When you are invading the body in any way, you want to make sure you use sterile technique. It is your responsibility to know when it's appropriate to use sterile technique, and if you're unsure, you can never go wrong. Principles of asepsis. Here's some basics. Microbes are transferred from one surface to another when touched. Okay? Put your hand on a table, whatever bacteria is on that table, when you touch your face, it is now on your face. Microbes are also carried on air currents. Legionnaire's disease is a good example of this. Legionnaire's disease usually is transferred if someone has like a HVAC system and maybe there's a leak in it, or anyway, it's when stagnant water sits and it's a reservoir, it grows bacteria, then the air conditioner comes on, blows that bacteria out into the public, and then people get Legionnaire's disease, or can get Legionnaire's disease. Now, that doesn't mean you can't be in anywhere that has HVAC. Legionnaire's disease is usually only transferred in severe and not so clean situations. Microbes are transferred by gravity. Again, go back to the airborne versus droplet. And they're transformed, again, in the air on droplets are water that come from the respiratory system. Here is another video. It's on donning sterile gloves. It's a pretty good one. You've already done this in clinical, but it's a good one for you to watch. So when this video is over, I suggest that you watch this video. Also, I'm going to post a couple other ones that are very good. So let's review principles of sterile technique. A sterile object or field out of your sight or an object held below your waist is contaminated. It's no longer sterile. A sterile object or field becomes contaminated by prolonged exposure to the air. You can't set up a sterile field, leave the room, and come back. You can't set up a sterile field 2 days before the actual procedure. A sterile object or field becomes contaminated by capillary action when a sterile surface comes into contact with a wet, contaminated surface. If you spill on your field, it is no longer sterile. There are 8 videos on YouTube, Common Errors in Sterile Technique. They're very good, and you should certainly watch them. And then, number 4, because fluid flows in the direction of gravity, a sterile object becomes contaminated if gravity causes a contaminated liquid to flow over the object's surface. So, let me give you an example. You prep a saline syringe to do a sterile wash, and you have it on your field, and the sterile syringe leaks. That would be an example of that. And then the edges of the sterile field or container are contaminated. So yeah, you have a 1-inch border around your field, but let's say somebody comes in, bumps it, and that 1-inch field like smacks right into your scrubs. That would no longer be sterile. Isolation is a great thing. It prevents a lot of things, but remember that when someone's on isolation, a lot of psychosocial things can happen. If the client feels they have something gross, C. diff is a big one, or MRSA even more so, because younger, healthier people get MRSA. You have to make sure the patient knows that it's not gross. It's not like they did something to cause this. Even if they're HIV positive, you cannot judge that person. You have no idea where they got it. You have no idea how. And their lifestyle, their choices are not your concern. You have to treat them same way you treat a patient with a broken leg. You have to plan to go in there often because they're lonely. A lot of staff and people don't like to go into isolation rooms. I don't have any problem with it. It only takes a second to put on the gown and gloves or whatever, and they need that kind of contact. They also need sensory stimuli. You know, if they're really sick, they need to sleep and rest, but whatever you can do to stimulate that patient. Also, to educate the family that it's okay to visit them. They just have to follow the same isolation precautions. Again, here's another video that's really good. It's from the CDC on the transmission of infection. All of the videos within this PowerPoint you should watch. And then, like I said, I'm going to be posting some more for you. So I wish you well on this, and we will review in class, but this will give you a good heads up ahead of time.